Hello everyone, welcome to my YouTube channel. This is Dr. Naz and today I'll be discussing about infectious mononucleosis, which is also known as glandular fever. Glandular fever or infectious mononucleosis is caused by Epstein-Barr virus, which is a DNA virus and it belongs from a gamma herpes virus family. Its mode of transmission is via saliva or aerosol. That is why it is also known as kissing disease. It is not highly contagious, therefore isolation of the cases is not necessary. So the patient may present with a complaint of fever, which can resolve in 2 weeks, pharyngitis or tonsillar exudates, headache, cervical lymphadenopathy. Posterior cervical lymph nodes are more commonly involved than anterior cervical nodes. Splenomegaly can also occur, and the spleen may rupture with severe exertion or deep palpation. Palate may have petechiae. There can be a periorbital edema. Hepatitis can also occur. Inguinal and axillary lymphadenopathy is also common. Antibiotic induced rash, 80 to 90% with ampicillin for sore throat. So whenever a patient gets sore throat and we will prescribe ampicillin to that patient, the patient will develop a rash which is going to be macular or petechial, and it can also be in the erythema multiforme type of rash. Occasionally a patient may have aseptic meningitis, encephalitis, etc. So you can see tonsillar exudates. These are whitish exudates, and on the other side it is ampicillin associated rash which occurs in mononucleosis. Complications may include airway obstruction due to severe pharyngeal edema or due to tonsillitis. Splenic rupture and hemorrhage can occur, as I have told you earlier, because of trauma or deep palpation or exertion. Thrombocytopenia is also a complication and it may lead to petechial palate. Neurologic complications can include cranial nerve palsies. X-linked lymphoproliferative syndrome, also known as Duncan syndrome, can also occur. So Duncan syndrome, as it is X-linked disease, so it occurs in boys mostly, and it is a rare genetic disorder that it causes immune system to overreact or hyperactivate to infection. Okay, so these are Epstein-Barr virus associated malignancies. It is a very important portion of this slide. So nasopharyngeal carcinoma, Burkitt's lymphoma, primary CNS lymphoma, and Hodgkin's disease. They are all cancers that can be caused by Epstein-Barr virus. Oral hairy leukoplakia and lymphoproliferative disorders can also be caused by Epstein-Barr virus. Okay, so jaundice, polyneuritis, meningoencephalitis are also few complications of Epstein-Barr virus. So for the diagnosis, we will have to see atypical lymphocytosis, which is a non-specific finding, but reactive lymphocytosis and atypical lymphocytosis is important. And these are the activated CD-T lymphocytes and also known as glandular fever cells. And we can also detect heterophile antibodies by using monospot test, also known as Paul Bunnell test. In the acute infection, there will be IgM2 viral capsid antigen, which is the most valuable and specific antibody. IgM antibodies to Epstein-Barr virus, early antigen. Initially, Epstein-Barr virus nuclear antigen anti-EBNA antibodies are absent, and they are present after 1 month of infection. So it will help you to diagnose the disease in retrospect. That means if after 1 month of this, if you check for anti-EBNA antibodies and they are present in the blood, then you will think that the patient had infectious mononucleosis 1 month back. So this picture is showing atypical lymphocytosis, also known as reactive lymphocytes. So you can see that these are large in size and they have eccentric nucleus, that is the nucleus is not in the center but it's slightly towards the periphery, and they have a foamy basophilic cytoplasm. So these are present in infectious mononucleosis. So the treatment of infectious mononucleosis is largely supportive. You will give analgesia, antipyretic, plenty of fluids is advised. If there is throat infection and you have performed throat culture and you find beta hemolytic streptococci group B, so you can give penicillin as well. Steroids can be given for 5 days if there is pharyngeal edema. Steroids can also be given for neurological involvement, thrombocytopenia and hemolysis, but only for a shorter duration of time, for less than 2 weeks around. Avoid contact sports or strenuous activity until splenomegaly has resolved, because there is risk of rupture. There is a 10% relapse rate of the disease. I hope you learned something from my video. If you have any query, you can ask in the comment section. Please do like the video and subscribe to my YouTube channel so I get motivation to make further videos. And thank you.